Coronavirus or malaria, tuberculosis and HIV. The UN warns the fight against one is threatening efforts made to control the others. What has the pandemic done to the decades-long efforts to control these diseases? This is Inside Story. Hello, welcome to the programme. I'm Bernard Smith. More than 7 million lives have been saved from malaria in the past 2 decades. But progress in fighting the disease has been hindered as efforts are diverted to the coronavirus pandemic. The World Health Organization expects the target for reducing malaria cases to be missed by almost 40% this year. Funding shortfalls and disruptions to treatments are putting thousands of lives at risk. Only $3 billion was received last year when more than $5 billion was needed. Interventions as simple as using nets and residual spraying can help prevent the mosquito-borne disease. The W.H.O is urging nations to step up their efforts for a world free of malaria. WHO says 229 million people were infected by malaria in 2019. The estimated figure has remained virtually unchanged over the past 4 years. Last year, more than 400,000 people died from the disease. Africa accounted for more than 90% of all global cases and deaths. Half of them were in Nigeria, Democratic Republic of Congo, Tanzania, Niger, Mozambique and Burkina Faso. The continent has significantly reduced the death rate since 2000, but that has slowed in recent years. While India is among the major contributors to malaria, the nation has been making progress in eliminating the disease. And the impact of coronavirus is also affecting the fight against other diseases. In addition to malaria, tuberculosis and HIV programs also reported about 80% of disruption in services. Tuberculosis diagnoses, for example, have dropped by nearly 75% in India since the pandemic began, while 1 in 4 people suffering with HIV reported problems gaining access to medications. Let's now bring in our guests. Joining us from Nairobi is Jeremy Herren. He's a scientist at the International Centre of Insect Physiology and Ecology. In Brussels, Martin de Smet, a physician and leader of the Doctors Without Borders Malaria Working Group. And in Kuala Lumpur, John Fleming, the Asia-Pacific head of the Regional Health Unit at the International Federation of Red Cross and Red Crescent Societies. Welcome to you all. John, I'll start with you. The Red Cross is the world's largest humanitarian network. Have you had to divert resources from things like malaria, TB and HIV to deal with COVID?
Absolutely, yes. In the last year, clearly COVID is the biggest operation, the broadest operation that the International Federation Red Cross, Red Crescent Societies has been engaged in. We, for instance, in the Asia-Pacific region, we have 38 National Red Cross and Red Crescent Societies, and every one of those 38 national societies are engaged in health and water and sanitation activities in respect of the COVID response. We also have activities for social and economic programs and, of course, capacity building for our national societies. So very much a major priority for the Red Cross, Red Crescent at the moment.
Jeremy, when you hear about resources being diverted, what does it tell you are going to be the challenges in trying to bring down the cases of malaria? There was this ambitious strategy set out by the Global Technical Strategy from the WHO to bring cases down by 90% by 2030. Already it suggests they're way off beam. What's going wrong?
Yeah, well, I think there's really a lack of investment, and that was pointed out, in the report. We're not really on track to meet the goals, and unfortunately, with the events of the last year, I think investment will probably take another hit. So we weren't on the right track with investment before COVID, and I think it's really. It's going to be really unfortunate as a lot of resources are diverted towards COVID, which is important, but there is a risk that people start to forget about malaria, which is really an incredibly important disease.
Martin, were those GTS, the Global Technical Strategy targets, too ambitious?
Well, I think it's good that the targets are and remain ambitious, but indeed the reality is that we were not able to meet these targets for a number of reasons, as mentioned already before. Not only due to COVID, but even before that, 400,000 people dying every year. You cannot call that, of course, being on track for a number of reasons that were present before COVID. And we see that lack of progress mainly in countries, conflict countries, unstable countries, post-conflict countries. Also, a number of environmental events that unfortunately continue to increase. Extreme events, weather events, flooding, leading to more and more malaria, technical problems linked to insecticide resistance, for example. So there's a number of reasons why it has been indeed very difficult to reach these targets, but we still have to do a maximum mobilization to come as close as possible.
And John, what other areas of healthcare are being affected by the concentration on fighting COVID-19?
Well, I think it's across the spectrum. I mean, according to W.H.O, UNICEF, over 80 million children under the age of 1 have missed out on routine immunizations this year, and an estimated 94 million children have missed out on measles vaccination this year. But it clearly goes beyond that. That's clearly extremely important. But many other secondary health effects as well in regards to clearly overstretched health care services, particularly in developing countries, which were already very badly stretched before COVID, are now stretched beyond their capacity. And again, you know, a lack of investment, as some of our colleagues have mentioned, in other really important areas. And then we're looking at, again, disasters that have been mentioned. So the secondary effects of disasters, both on populations, migrant populations, and then the looming threats of socioeconomic challenges, mental health and psychosocial challenges that are on the horizon, indeed, have already manifested themselves.
Jeremy, more than half the malaria endemic countries have reported disruptions to malaria diagnosis and treatment. What are the consequences of that if you're not diagnosing it earlier on? What chain of events does that create?
Well, it's a disease that operates very quickly. So, you know, if people are not getting diagnosed in a timely manner, getting medication, then the rate of mortality is going to increase very significantly. And I think we have seen that this year. The levels are definitely going up. It's hard to say exactly by how much. And the worst may be still to come, because I think a lot of the economic impacts of the pandemic are still coming. And I think that will have major effects in sub-Saharan Africa, where, of course, as you mentioned, malaria is the worst.
Martin, have the Doctors Without Borders teams been reporting delays in diagnosing malaria? What are their concerns?
Well, we are, of course, also observing delays in the places where we work, very often linked to the whole logistical implication of COVID lockdowns and travel restrictions, drugs, diagnostics, bed nets that cannot just be shipped and arrive in the usual way. But maybe if you allow me, I would like to say that there are also some positive aspects, because from the beginning, we all understood that this was going to be a major challenge with a very high risk of exploding malaria deaths. And fortunately, there has been a huge mobilization among the different actors to invest as much as possible in prevention. And in fact, this was quite successful thanks to that good collaboration. Just one example, there is a nice strategy that protects now children from malaria, mainly in the Sahel. It's called seasonal malaria chemoprevention, where the children do receive, and that's millions and millions of children, receive anti-malarial drugs during the transmission season on a monthly basis. We were all afraid that this would completely collapse because of the COVID, the logistical challenges, the movement restrictions. But thanks to a huge mobilization, national control programs, World Health Organization, NGOs, UNICEF, to our own surprise, in fact, all these interventions did take place in the countries as they were planned, basically, with only some minor disruptions. A lot of the bed net distribution campaigns did take place. So I think there was a shift to, we really have to invest in the prevention now that we have still the opportunity, the window of opportunity between lockdowns and movement restrictions. And I think this really was helpful to reduce the impact of the COVID. On the other hand, we do see, and it's now a daily struggle indeed, to make sure that there are sufficient drugs and diagnostic tools on the ground. And this ranges from indeed manufacturing issues. The reality is that we're very happy that there are today good tests to test COVID, but it's basically the same production lines in the same companies producing malaria tests. So it's a daily struggle to make sure that we still have sufficient malaria tests, the whole logistical challenge to bring the drugs over there. And then in many countries, the impact on lockdowns, travel restrictions. People can't get to the health centers sometimes. So we observe very worrying and concerning developments. And at the same time, we see encouraging dynamics, as I mentioned, through that strong mobilization, very close follow-up, the different agencies looking together how we can swiftly react to the needs. So that's a bit our observations.
John, while there is good positive news from Martin there, he mentions, I know, the diagnostic tests. Now, these rapid diagnostic tests, they make profit of about 18 cents a test, I understand, for the manufacturers, whereas the coronavirus is much more lucrative. The test is $10 a go. Does the Red Cross see problems in getting these tests produced and distributed and provided because capacity is being switched to coronavirus testing?
Yeah, our main role, frankly, in both in coronavirus and also in malaria is creating demand for tests as distinct from carrying out the testing. And maybe some national societies that do so. But the key, if I may say, comparative advantage of Red Cross, Red Crescent is in social mobilization, in generating interest in testing, or interest, of course, in demand creation, if I may say, for bed nets, for treatment, for testing. So a lot of our work is at the community level. It's based on our coverage through the branches, and of course with the volunteers as well. So a lot of it's based around advocacy. It's based around rumor management, social mobilization, and also, as I indicated, engagement, social engagement. So from the testing point of view, clearly it's of interest to us, and in many cases, as I say, national societies may get involved in testing, but for the most part, our comparative area is working with governments, it's working with the agencies that colleagues have mentioned here, but it's utilizing our comparative advantage around the coverage at the grassroots level.
All right. Jeremy, can you just help us understand what the new formulations of artemisinin combined therapy, the improvements of them have made for the treatment of malaria, and the introduction of these rapid diagnostic tests? What difference are they making?
Well, a huge difference. I mean, the availability of ACTs has really made it possible to treat people across, Africa and the world. The treatments are cheap and effective, and so far have had a relatively minimal amount of resistance from the side of the it's been a very, very effective way of controlling the disease. But there is, a cautionary note that it will not last forever. Resistance always evolves. And that's why, research and development is incredibly important, so that we have the next line of drugs available when resistance evolves, as it most definitely will. So we really can't rest on our laurels with this one. What we have is working at the moment. That's great, but we've got to look to the future as well.
But Jeremy, are people getting reliable access to those drugs at the moment? Because, of course, resistance builds, doesn't it, if people don't use the drug regularly and there are gaps in treatment?
Yeah. Well, I think a lot of there has, especially this year, but even in other years, there were challenges in getting access to, even some of the most remote places in sub-Saharan Africa. So I would say that, there's been a lot of effort and a lot of improvement, but we're still not there yet. And the challenges of this year, it's a little bit hard to say exactly how much effect it's had. And of course, in different countries in Africa that have been affected more or less by coronaviruses, the levels of blockage in the sort of supply chains is different. But what we know is that there has been an effect, and that is unfortunate.
Martin, have your teams reported a fear of people going to clinics because they're going to contract coronavirus? Have you been able to counter that?
Yes, we did observe that for indeed people accessing the health center. Fortunately, there is indeed, as was already mentioned, quite some investment in community-based treatment, where people can get the treatment for the basic diseases, including malaria, in their own village. But indeed, we observed a fear on different levels. Sometimes it's the patient who's afraid to attend the health center. Sometimes the health staff is afraid of going to work because they're afraid, especially in the beginning when there wasn't yet enough personal protective equipment available, that staff was afraid to go to the health center. And on top of that, there were, in a number of African countries, strict rules on movement, also reducing this access. At the same time, we were also fearing that the same factor would play for these preventive activities, for example, attending a bed net distribution, attending vaccination campaigns for measles, for example. And so we really, and I think all the actors really invested a lot in health promotion, explaining clearly to the people that the risk wasn't really there because the ways were organized in a safe way. And at the same time, also thanks to the World Health Organization, but together with all the partners, there was very clear guidance issued on how can you deal with, for example, a bed net distribution in a COVID context? How can you reorganize your circuits in a clinic in a context of COVID transmission ongoing? So it is a problem, but fortunately, with good health promotion, good guidance on how to adapt, reassuring, I think this is less disruptive than we feared in the beginning. But no one can tell what's going to be in the future, of course, because rumors spread very easily in Africa. Rumors of spreading COVID during a vaccination campaign, for example, has a huge impact on the coverage of the future campaigns.
And John, how do you mitigate those concerns that people have? People nervous to come for treatment because they fear they're going to get coronavirus, which means TB doesn't get identified early enough, or malaria doesn't get identified.
Right. Yeah. So we've got a number of let's say inroads into this, or means of engaging communities. Of course, in the context here in Asia Pacific, many countries there's a high usage of social media, so we can relay clear, accurate, precise messaging to people through various means. we're working in many of the communities anyway, so we have that trust. But certainly, as my colleague has mentioned, this building trust and dealing with rumors and misinformation through communication, risk communication, generating trust. I mean, it is a huge area, but also it was mentioned the disasters. We're in the midst of the typhoon season here now. We've had a number of significant typhoons, particularly in the Philippines and in Vietnam. So again, building in risk communication and utilizing our means of getting accurate information to people. I think that's certainly one area that we and many other organizations, such as ones that are represented in this panel, are engaged in. But it is definitely a real struggle. There's a lot of misinformation there in regards to COVID, but also in regards to the let's say going to health facilities. So it is it's certainly a big chunk of work for us, and no doubt for other organizations as well, in getting accurate messaging across and dealing with this.
Okay, all right. Jeremy, can I ask you if you're aware of this new bit of research from Germany and Mali into why malaria persists during the dry seasons when hardly anyone gets sick and there are too few mosquitoes to carry the parasite, suggesting that mosquito performs some sort of genetic change to lie in wait, waiting for the wet season. What difference does the discovery of this make to the development of an eventual vaccine?
Well, I think that's a very important discovery because, of course, if you can prevent mosquitoes from holding malaria from one season to the next, then you can, it's much easier to eradicate it. So you can prevent that sort of transmission across seasons, because malaria does kind of disappear when there are no rains in a lot of places that are, have epidemic levels of malaria. And so, if you can target that particular stage, it could be sort of a weak link in the parasite cycle. But I think it also underscores the need for more research to really understand the whole malaria cycle and the biology of the vector, so that we can find these sort of low-hanging fruits, weak links that we can then target as part of new interventions, which I think are really going to be the key to ultimately eradicating malaria. And until we sort of reach that goal, we're always going to have these types of challenges. Every time we have, an outbreak of a different disease, it's going to compound the efforts of trying to control malaria. All
right. And Martin, can I lastly ask you, with all the billions and billions of dollars that's been poured into finding COVID vaccines in the last less than 12 months, if that had been committed to malaria, would we have a vaccine today? Would we have got rid of it, Martin?
There's, of course, a big difference. And now there has been a lot of investment in the malaria vaccine. And fortunately, the last trials are ongoing, are encouraging. But indeed, I think the first discussions and the first steps in the development of that vaccine started when I was still a university student, I think. So that huge boost, especially when it comes to the timeline, of course, that would have helped a lot for malaria as well. There is a lot of investment, but unfortunately, the results still have to be proven. And but well, we hope that the success of the COVID vaccine, following the success of the Ebola vaccine, will also lead to a further sustained and increased investment in the development of the malaria vaccine, or of one of the malaria vaccines, because there are several in the pipeline, but in very different stages of development.
All right. Folks, unfortunately, we are out of time, but thank you to all our guests, to Jeremy Herren, to Dr. Martin de Smet, and to John Fleming. And thank you too for watching. You can see the programme again anytime by visiting our website, aljazeera.com. And for more debate, go to our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter. Our handle is @AJ Inside Story. From me, Bernard Smith, And the whole team here, bye for now.